Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is HIV and OI respiratory system, and the speaker is Dr. Anwar Parvez Sayed. Dr. Anwar Parvez Sayed is a public health specialist. He is an affiliated clinical associate professor at the Department of Global Health of the University of Washington, and also a doctoral candidate in the Global Health Leadership Program. He is currently working as a consultant with the Department of Communicable Diseases, WHO, East Mediterranean Regional Office. We welcome you, sir, for today's session and request you to start the session.
Thank you, Shweta, and good afternoon, everyone. Welcome again to this session, and today we'll talk about respiratory system and the national guidelines in relation to that. And our basis for the session will be the national guidelines for HIV care and treatment of 2021. This session, I know that you might have already heard in NDLS. So this is an RDLS, will be a recap of most of the slides. The slides are almost the same. And those who have worked in the ERT centers, they might have seen so many cases of respiratory illnesses in past and also must be seeing now. But this will be, I think, a good revision of some of the basic principles of diagnosis and treatment of these important group of opportunistic infections. So in this session, we will talk about a few important organisms which in relation to HIV. One is tuberculosis. Of course, this will be a rapid run through because this itself is a separate topic which I hope you had attended in past. Then PCP is another important organism, Pneumocystis jirovecii pneumonia. So that is another disease which we will be talking about. Bacterial pneumonia is again very common in both HIV positive and unvaccinated non-HIV. Mycobacterium avium intracellular complex, or MAC, is important if the immunity is severely compromised. And tuberomycosis, which is also called as penicilliosis, the name has been changed in recent past, is specific to Northeast, especially Manipur. And there are some other pathogens like Aspergillus. So these are like important list of organisms. Of course, respiratory system is something which is really vulnerable, I would say, for all diseases because it is directly exposed to the atmosphere, and there are so many other infections, especially in the era of COVID and other influenza and other viral infections. We see patients presenting with these symptoms so often these days. And also there are patients who present with these symptoms which they have because of non-infective causes, like if they have allergies and things like that. So, but fortunately, many of the serious opportunistic infections are preventable. If patients are on preventive therapy, you can prevent that. And also, we can easily diagnose them and treat them. They are treatable. HIV associated other diseases are related to like upper respiratory tract, like sinusitis, bronchitis, pneumonias are most diagnosed bacterial respiratory infections. If we compare that with the CD4 cutoff levels, we all know that TB is one of the most common OIs, especially in severely immunocompromised. But TB can happen at any CD4 count. And patients are at more risk of developing active TB if the CD4 falls below 400. But the presentation of tuberculosis is different in an immunocompetent person and an immunocompromised person. In immunocompromised, it will be more of disseminated form of TB and more of extrapulmonary TB. We'll see those details in a few minutes. Then pneumonias, especially those patients who are unvaccinated, bacterial pneumonias are common in them with CD4 less than 250. Then pus producing or suppurative lung diseases and sinus disease if CD4 count is less than 100. Usually we try to diagnose these infections because, for example, PCP, if you cannot confirm the organism in the lab, the most of the cases are diagnosed clinically and treated clinically. So if you want to diagnose these infections, we actually take the help of CD4 counts. If the CD4 counts are below certain cutoff, we can put certain organisms on the top of our differential diagnosis. For example, if a patient presents with typically dyspnea and fever and dry cough, but if CD4 is 800, I would not think of PCP as my first differential diagnosis. But at the same time, with the same symptoms, if CD4 count is less than 200, then we think about PCP first before other differentials. Similarly, MAC is common or can happen if CD4 is less than 100 and cytomegalovirus less than 100 or less than 50. So let's start with TB, the most common opportunistic infection in HIV positives. Usually, and it's most common cause of death also in people living with HIV. So TB in HIV positive or immunosuppressed HIV positive patients reduces the ability, that condition reduces the ability of the body to kill the bacteria. And if HIV positive person has TB, the TB has an effect of HIV in the sense that it causes more inflammation, which leads to increased multiplication of HIV and rapid progression to AIDS. And if we compare presentation of TB from pulmonary to extrapulmonary, pulmonary TB is most common form of TB in all populations, especially in general population. 80 to 85% of the TB is pulmonary and 15 to 20% of the TB is extrapulmonary. But in HIV positive, because of the reason which I just mentioned on the previous slide, that if the immunosuppression is high, we get a disseminated form of TB, and that's how we get extrapulmonary TB in HIV positive, which is almost to the extent of 40%. Also, that there are diagnostic challenges in HIV positives, especially in the late stages. It is difficult to collect samples and test and establish the diagnosis. Sputums are usually negative. So one of the things to note from this slide is I guess how many times there is increased risk of TB in HIV positive. It is 16 to 21 times, which is very considerably, like, very high. So, and that is irrespective of the patient, of the fact that if the patient is with or without ART. Sometimes people who are immunocompetent, or in the sense what I'm trying to say is, if the immunity has been restored, if the CD4 count is high, HIV positives, they might think that if because CD4 is good now, there is no risk of TB disease. But that is not true. Even if the immunity is restored, even if the patient is on ART, the risk of TB is much more higher in HIV positives than in HIV negatives. So this is impact of one disease on another. Like I said, if the patient is HIV positive and has TB, the HIV causes severe immunosuppression, and also it causes progression of HIV infection to TB disease much faster than HIV negative patients. And also recurrence is something which is more common in HIV positives, and because and one of the reasons of that is it leads to more percentage mortality in HIV positives. And TB affects HIV in the sense, like I mentioned, it causes severe inflammatory reactions and in response to TB bacilli, and that causes increase in viral replication and rapid progression of HIV infection, and which leads to AIDS, and that causes high mortality. This is about like presentation of tuberculosis in early and late phase of HIV immunosuppression. So early phase of immunosuppression, can be also similar to immunocompetent. We can, in other words, we can say that as an immunocompetent state, or people who are HIV negative, they are similarly presented. So in which you will see uh, um, usual signs and symptoms of TB. But TB in HIV positive is usually like a primary type of adult tuberculosis, in which we will not see the typical upper lobe involvement with cavity formations. But if the immunity is a better the immunity, you will see more of cavity and granulomas and infiltrations, and basically you will see something on the X-rays. But in the late stage of immunosuppression, there is a delayed or late, or there is no um, immune reactions. And that is why you don't see typical presentation of tuberculosis. There won't be any cavity formation. So a typical presentation like mid-zone and lower zone involvements, and you will see maybe like interstitial involvement, or mediastinal involvement with enlarged lymph nodes, and also you may see pleural effusions and sometimes pericardial effusions. So those are typical presentations of tuberculosis which happen at the late stage. And when you have cavity, it is more likely that you might find organism in the sputum. So when you test by smear examination or by CB-NAT, you will get often positivity. But if there is no cavity formation, the sputum which patients bring out may not have TB bacilli or may not have the antigen. And that's why you will see mostly smear tests negative. So in the ART center or in HIV positive patients, the approach is to find out case faster than the usual approach. So it is called an intensified case finding, where we do active case finding. We don't wait for patients to complain about TB symptoms, but we proactively ask them if they have current cough, if they have fever, if they have weight loss, or if they have night sweats. So these are called as 4-symptom complex. So if patients have any of these 4 symptoms, then we uh, and those patients will be called as TB suspects, or they need to be further investigated for diagnosis of tuberculosis. So these are also called as presumptive cases of tuberculosis. Of course, anyone who has cough or fever or weight loss or night sweats may not have TB, but if they have TB, most of them will have at least one of these four symptoms, and that percentage is pretty high, which is more than 98%. So 98% of the patients who have TB will have at least one of these 4 symptoms. It is called as negative predictive value. So if they do not have these symptoms, they may still have TB, but if they but that need to be again further evaluated. In children, the 4-symptom complex is a bit different. Like it includes cough, current cough, fever, poor weight gain, and history of contact with TB case. So if you find any of these symptom in any of HIV positive coming to the ART center, we need to fast track these patients. We have to refer them for TB diagnosis, in which we do CB-NAT on the sputum and other samples if when it is required. So this is the algorithm which we follow. This is from the medical officers training module of 2020 of NTEP, National TB Elimination Program. So if there is a presumptive TB case, generally we see if the person is HIV positive or negative. If patient is HIV positive, we directly go for CB-NAT, and then based on the result we take the decision. But if HIV negative, it depends. There are situations where smear examination and X-ray will be helpful in making the diagnosis. So if CB-NAT is positive, which means it is microbiologically confirmed TB case, CBNAT will also tell us if there is rifampicin sensitivity or resistance. So if rifampicin sensitive microbiologically confirmed TB case, we treat those patients with regular 6 months of anti-TB treatment. But if it is indeterminate on CBNAT, then we take a second sample and then test that, and that if that is also indeterminate, then we collect a fresh sample for liquid culture or line probasis. If rifampicin is resistant, we from ART center straight away refer those patients to DRTB center for management of DRTB drug resistance tuberculosis. And if CBNAT is negative, if MTB is not detected on CBNAT, then we consider alternate diagnosis, or we see other clinical uh, um, supportive evidence to make a diagnosis of TB. For example, chest X-ray shows signs and symptoms of TB, or maybe CT scan finding, ultrasound, or maybe any other um, 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 proof to say that it, or to support the diagnosis of clinical suspicion of TB. So this is a gray area where the clinicians' skills will jump in, and they matter more than the evidence which is presented. So based on your experience, if you decide to treat that patient with full course of anti-TB treatment, we can label that case as clinically diagnosed TB and we can start. But again, we need to take help of the supportive measures of diagnosis. And for extrapulmonary TB, if we can take samples, if clinical sample is available, then we subject that sample to CBNAT. If mostly CBNAT will be negative, but if it is positive, it confirms the diagnosis. If negative, again, see the histopathological picture if possible, and if you think that it, and clinical picture obviously. Clinical example, like if there is cervical lymphadenopathy, and if you are doing FNAC, and FNAC usually shows just um, uh, some macrophages, or it's not conclusive, for example. Then in those cases also, if clinically, if you see clustering of lymph node at one place, and if there are multiple lymph nodes, and if you suspect, you can still start ATT based on like clinical grounds. And if sample is not if negative or not available, then obviously if there is high clinical suspicion, and if there are other modes of diagnosis, you can still go for it. If not, then you can very well start a anti-TB treatment if you strongly suspect TB in those cases. And liquid culture is another option. If culture is positive, then we confirm that as a microbiologically confirmed TB. And if culture is negative, it will be either no TB or clinically diagnosed TB. So this is just to enlist the tools available to use for microbiological confirmation of TB. So CBNAT or TrueNAT, which is more sensitive, but based on similar principles, these are cartridge-based nucleic acid amplification test. It is also commonly called as Gene Expert if you in the international platform. So the most important advantage of this is that it is very easy to perform, and you get quick results within 2 hours of time. And also it will not only say about positivity, but also will tell us about if the sample is if the bacilli are resistant to rifampicin or not. So that's why it's very useful, and it has been a game changer in TB diagnosis. It has because previously we used to send if a person is not responding, we used to do LJ medium culture on LJ medium, solid medium, and it used to take like a long time, like 2 months. And most of the times we used to lose patients, because obviously if you are not treating patients for 2 months and who require treatment, what are the chances that patients will survive? So CBNAT has been really useful. And in line probe assay, there are two line probe assays. One is LPA1, which is for our first line LPA, which will tell us about resistance to INH in addition to rifampicin. Rifampicin, we get that result on the CBNAT, but if patient is sputum positive, we also do first line LPA in all patients to see if there is additional resistance to INH or not. And for MDR TB diagnosis and the DRTB center, they say second line LPA if there is resistance to rifampicin on CBNAT. So second line LPA is done for fluoroquinolones and second line injectable drugs like amikacin and kanamycin and those. So liquid cultures are, these are a couple of examples like bacterial liquid culture and Mycobacterium growth indicator tube assays. So in practice, these are required only if we are not able to diagnose with Lyme probe assays. For follow-up tests, obviously, if you do the NAT test for follow-up, they will pick up the RPO-B gene from the dead bacilla as well, and which might give a wrong impression. So that is why NAT tests are not useful for follow-up as a follow-up investigation. But smear examination are helpful. So that is why when we do follow-up testing, smear examinations are still used, ZN staining and fluorescence staining. So these are basic principles of management of patients or TB patients. So intensified case findings, that is active case finding using 4-symptom screening is done. And if we find anyone positive for 4S symptom, then we fast track those patients for especially those who are symptomatic for CBNAT test and appropriate investigations. And if we find active TB, we start those patients on anti-TB treatment on priority. And all patients who are started on TB treatment, they have to be started on ART within 2 weeks, regardless of CD4 count. But there is only one exception, which is TB meningitis. So if the patient has TB meningitis, the recommendation is to delay ART initiation in those patients because there is severe risk of immune reconstitution syndrome, and you may lose the patients if they are not sufficiently treated with anti-TB medications. So there are only two conditions where we delay ART initiation. One is TB meningitis, another one is cryptococcal meningitis. So where we have to make sure that patient is sufficiently treated with the treatment of OI, and which is usually 4 to 6 weeks. And then after that, you can start the ART in those patients. So, and regardless of any CD4 count, all patients who are taking treatment should be on cotrimoxazole prophylaxis, especially if they are having CD4 less than 350. But in case of TB co-infection, there is no CD4 cutoff as such. So that was a rapid recap of TB diagnosis and management. So the next organism we will talk about is Pneumocystis jirovecii pneumonia, or PCP. Some people say it PJP, which is not necessary actually, because that middle C stands for cystis, because this forms cysts in the lungs, and that is why it is called as PCP. But some people interpret that as Pneumocystis carinii pneumonia, and that the C stands for carinii. It's okay, not a big deal, but you can still use PCP because C stands for cyst. So it's a ubiquitous fungus. There was a long debate about this organism, but finally it has been decided that it will be under ubiquitous fungus category. So, but these days we are not seeing many patients of PCP. One, because we are starting ART irrespective of CD4 count. That is, patients who are having higher CD4 count are still receiving ART. And also because we are giving prophylaxis. So because of these reasons, we are not seeing PCP cases as frequently as we used to see in past. So 20 to 30% of the PCP, it occurs in AIDS patients, which means like CD4 count less than 200. and mortality is high if there is PCP and if it is not treated. And most of the patients, or almost 90% of the patients who has PCP, will have CD4 less than 200. And usually in non-HIV or HIV negative people and healthy, the usually antibodies are generated or formed in body by second year of life, second to fourth year of life. That is why you won't see PCP in HIV negative people. So dyspnea is main symptom of PCP, and another symptom is dry cough. So patient presenting with CD4 less than 200 and having dyspnea, and sometimes exertional dyspnea, not at rest, but if they do some exercise, they will develop dyspnea. And dry cough, some fever or fever may not be there, and if you see oxygen saturation or partial pressure of oxygen, it will be low. Sometimes that also is deceptive, because of rapid respiration, patient maintain the oxygen saturation for some time, and that's why you may not see hypoxemia in these patients. And on the chest X-ray, it can range from normal to having ground glass opacities. So in early stage of PCP, chest X-ray will be normal, but as disease progresses, you may see perihilar infiltrates, reticular or reticulonodular infiltrates. Pleural effusions will not happen in PCP, but there is a risk of pneumothorax in patients with PCP. So either perihilar or lower lung field involvement will be there. And if when disease progresses in severe stages, you will see ground glass opacity across the both lung fields, and which is very serious stage. Usually ICU patients will have that kind of picture. So in children also, symptoms are more or less similar. Auscultation will not reveal anything. You might hear lower inspiratory crepitations, but otherwise, usually auscultations will be normal. So the key is to keep a clinical suspicion, and based on the clinical presentation, you can make a diagnosis and treat the patients. But in children, again, the way we define dyspnea is different from adults. In adults, usual or normal respiratory rate is 12 to 16 or 16 to 20 based on which book you are following. But in children, tachypnea is defined based on the age. So in infants, even like 60 or like 50 respiratory respiratory rate of 50 may be normal. So depending on the age, you actually decide if there is dyspnea or tachypnea or not. So like I said, if you want to confirm the diagnosis, you will have to do bronchoalveolar lavage or induce sputum examination, but which is, I don't think it is clinically feasible, and also it is not required. In most of the cases, because treatment is so simple and straightforward, you can still start treatment with high-dose cotrimoxazole. But obviously, if you have this clinical suspicion, this is, I think it can be tried only if you're treating with everything, if patient is not responding, and if you want to consider any alternate diagnosis, then you can go for bronchoalveolar lavage, for which obviously you'll require bronchoscopy. So otherwise, I don't think it is necessary. So you can um, do a presumptive diagnosis based on clinical signs and symptoms, correlate with CD4 count, see if the patient has any other stage 3 conditions like oral candidiasis to tell us about immune suppression if CD4 is not available. Then if patient is not on prophylaxis, that is one very good key, I would say. If CD4 count is less than 200 and if the patient is not on cotrimoxazole prophylaxis, that should actually raise the alarm. And obviously, if there is signs of hypoxia or hypoxemia, and chest X-ray shows signs and symptoms. Another supportive, I would say, evidence can be lactate dehydrogenase or LDH. So if the LDH is high, it is actually a bad sign, which indicates severe PCP. So like I said, definitive diagnosis, you'll have to see organisms under the microscope, which is not, I think, feasible or necessary also. So this is about like how to get the sputum, because these patients, like I mentioned before, will have dry cough. But if you want to induce this sputum, you'll have to give hypotonic saline inhalation and or nebulization. It's not that easy, especially once you have patients in front of you with all these signs and symptoms. You cannot ask for inhalation and with hypertonic saline. So it's theoretical mostly. So prophylaxis is something which is very important to know and remember for HIV positives. So as per current guidelines, all patients who have CD4 less than 350 should be given cotrimoxazole prophylaxis. Even though I mentioned before that if CD4 is less than 200, the risk of PCP is higher. But cotrimoxazole prevents not only PCP but other infections, including bacterial pneumonia, including toxoplasma. So because it has a wider benefits, it makes sense that if the CD4 falls below 350, you should start patients on prophylaxis. So it is not only for PCP, but it is for other organisms, including diarrheal diseases, or if the patient has any WHO clinical stage 3 or 4 condition. Then secondary prophylaxis, primary prophylaxis is before you get the disease. Secondary prophylaxis is you have the disease, you treated the disease, now you want to prevent the relapse of that disease, and that is why you give cotrimoxazole prophylaxis in those patients who develop PCP until unless their CD4 goes above 350 on the 2 occasions 6 months apart, which means that there is sustainable or sustained immune reconstitution. So cotrimoxazole has trimethoprim and sulfamethoxazole combination in the dose of 160 and 800 milligram, which is called as double strength dose. You get tablets of cotrimoxazole DS, and single strengths will be half of this strength. So either one double strength tablet or 2 single strength tablets can be given. Those who are allergic or are intolerant to cotrimoxazole, you can give dapsone 100 milligram. But sometimes you get allergy, mild rashes, and in those cases you can still try desensitization. And as I said, if you want to discontinue cotrimoxazole prophylaxis, the CD4 should be more than 350, and at least on 2 occasions 6 months apart, which will and patients do not have any stage 3 stage 4 conditions, which proves that the patient's immunity is restored. So yeah, we already saw this. And dosage of cotrimoxazole we again saw. Breastfeeding, it doesn't matter if the person is pregnant or breastfeeding, if the woman is pregnant or breastfeeding, and in any case we can give cotrimoxazole to all those women. And as I said, if the patient is allergic to sulfa based medications, you can give dapsone, or you can try desensitization with cotrimoxazole. But if the first reaction is severe, you should not re-challenge that patient with sulfa containing drugs. And there is usually no monitoring is required in these patients. And when you want to start a new patient who is not on any treatment or newly diagnosed, then you start cotrimoxazole on day 1 of the consultation, day 1 of the visit to the ART center, so that by the time patient is prepared for ART initiation, you would know that if there is any rash or not. But if you start ART first or start both the treatments simultaneously, if the patient develops a rash, it becomes quite confusing. You would not know if the rash is because of cotrimoxazole or because of ART, and that is really that becomes further complicated if the patient is already on anti-TB treatment. So that's why it makes sense to start cotrimoxazole first, wait for some days, see if the patient is tolerating cotrimoxazole well or not. And also it will tell you how adherent the patient is. So if the patient is following as you said, that means patient listens to you and I have understood everything, and it is good time to start ART. So it will also give you, but you need not wait for like 2 weeks or so. And in patients who you know that will not be able to come if you call them next day for ART initiation, better to start both treatments simultaneously than to lose patients and end up not starting ART in those patients. So those are like practical decisions a medical officer will have to take based on patients. But ideally, cotrimoxazole should be started first, and you should wait for a few days and see if the patient is tolerating cotrimoxazole well or not, and then you start ART. But again, like I said, if there is risk of losing patients and patients are traveling long distances to come to you, don't miss that opportunity and start ART in those patients. This is about desensitization of method, which can be tried. I never tried this personally, but again, this is one of the options if you have to give cotrimoxazole. You start with small doses like oral suspensions, and you go on increasing dose every day. There is a typo error in this slide. Day 5 should be like double the dose and like 400 milligram of sulfamethoxazole, and again almost like 100 or 120 milligram of trimethoprim. But again, you can use oral suspension if available, or single dose, single strength, or half the dose, so which is also fine. In children, all HIV exposed children should be given cotrimoxazole prophylaxis from 6 weeks of age. Why 6 weeks? Because that is usually the first encounter to the health facility. And all these patients should be given cotrimoxazole unless their HIV is ruled out at 18 months of age with the negative antibody test, regardless of the patient or the fact if the patient is on ART or not. This is a bit like illogical, because if the patient is antibody at 18 months is negative, why ART should be continued after that? But this is a gray area again where there is a lot of confusion. People do not feel safe for stopping ART at this point as well, and usually experts take decision what is to be done for those patients. So just to get away with all those confusions, we can just say that if antibody test is negative at 18 months, you can stop cotrimoxazole in all patients exposed to HIV, all children exposed to HIV at birth. But otherwise, if the children or infant is HIV positive, diagnosed with DNA PCR, then you have already established the diagnosis, and then all these patients, regardless of CD4 count or WHO clinical stage, will receive cotrimoxazole prophylaxis unless they pass the age of 5 years. And even after 5 years, when you want to stop cotrimoxazole, you'll have to look at CD4 count, and which should be more than 350. Then again, in the interval of 6 months apart, which will prove as the immunity has been restored. And patient should not have WHO stage 3 or stage 4 condition. Stage 1, stage 2 is fine, but stage 3, stage 4 condition should not be there. So yeah, so this is again repetition of the same thing, more or less, that if the age is more than 5 years, treat that person like an what we said already in adult, including secondary prophylaxis. So this is about dosage chart. You need not remember any of this. You just refer to this chart. If the patient comes to you, you can keep it handy. You can take a printout and keep with your pharmacist or with you. And based on this chart, you can just see the weight bands and age. And based on that, you can decide the dose. Obviously, if you have in the artisan available, the suspension, usually it is a bit challenging. So this is how management of PCP is done. The dose is high dose of cotrimoxazole. High dose means in the dose of 100 milligram per kg per day, usually in 3 to 4 divided doses. But just for rough calculations, for every 8 kg, you give one double strength tablet of cotrimoxazole. For example, if the patient is weighing, suppose 40 kg, you give cotrimoxazole in the dose of 2 tablets in the morning, 2 tablets in the afternoon, and 1 tablet in the evening. That is 2 to 1, which is 5 tablets. So 8 kilogram, 1 tablet of double strength. And if the weight is 40, 8 into 5, that is 40. And that is how you give 5 tablets That is just to make the calculations easy. Otherwise, you can, based on exact weight of the patient, you can calculate the dose of double strength tablet and you can give. There are other alternatives which can be used, like primaquine, atovaquone, in case patient, or dapsone, obviously, if you are not able to give cotrimoxazole. And the entire duration of treatment is 3 weeks, that is 21 days. um, but severe cases, and especially those cases who have hypoxemia, steroids are really helpful. So you can give steroids in the beginning with like 40 milligram dose of prednisolone, which you can taper after some time before stopping. So with reduced doses of steroids and systematic stepping down of treatment can be done. So duration is 21 days. So this is high dose cotrimoxazole treatment of PCP in children. This is how, again, you don't need to remember this. You can just take the help of this chart. Okay, so that concludes PCP. Let's talk about bacterial pneumonias. So these are like most common diseases in HIV positive: TB, PCP, and bacterial pneumonias. Bacterial pneumonia is again, there is increased risk in, especially if the patient is not on ART. There are risk factors for bacterial pneumonias in elderly. If you have other lung conditions, if the patient has other lung conditions like COPD, malignancy, renal insufficiencies, or even heart failures, so there is an increased risk of pneumonias. In children, those who are malnourished or have other lung conditions like bronchiectasis or other chronic lung diseases, and they are at higher risk. But generally, if the patient CD4 is low and if the ART is not yet started, or ART is not regular, and patient is alcoholic or smoker and tobacco, takes tobacco and injection drug use, those patients also will be at higher risk of developing pneumonias. And because there is a risk of aspirations in hospitalized patients, will also have like increased risk of pneumonias. So usually, if you want to differentiate between pneumonia, PCP, and TB, pneumonia typically will have shorter duration of symptoms. Fever will be very high grade, and patients may present with septicemia sometimes, but cough will be usually productive. Typically, pneumococcal pneumonia will have khaki colored sputum or brownish sputum. And there will be dyspnea, there will be history of chest pain, and there can be pleurisy. Initially, chest pain is usually because of pleurisy or maybe involvement of pleura, and which rub each other and which will cause pleuritic chest pain. But after some time, there is development of parapneumonic pleural effusions, which separates the pleura, and there won't be any chest pain after that. But if the effusion increases, there will be history of dyspnea. So this is, in nutshell, the presentation of pneumonias. And if you compare that now with PCP, where we have seen dry cough, dyspnea from day one, or maybe there is nothing on auscultation. While in pneumonias, you may find bronchial breathing and maybe like signs of pleural effusion, which were not there in PCP. Tuberculosis can also present like a tubercular pneumonia, but that is not, again, will have the shorter duration of symptomatology. It will have a bit longer duration of symptoms. In children, you may see chest indrawing and tachypnea, but as I said, please remember that respiratory rate in adults and children is quite different, and in children it is based on age. You should never forget some danger signs in children, because children, they deteriorate very fast and you may lose them if these danger signs are not kept in mind. These are not able to drink or breastfeed, persistent vomiting, convulsions, or poor sensorium, or stridor. There is noise from the throat, and then calm child or associated bacteremia. So yeah, less than 5 years, cough and cold, no pneumonia. Um, we need not give anything to the patients. Uh, Fast breathing and chest indrawing pneumonia, amoxicillin and home care advice. And if there are serious signs and symptoms of pneumonia, then antibiotics are required. Now, again, one point here that respiratory symptoms these are so very common, and we are used to given antibiotics in all patients who have some cough and sputum and maybe like greenish sputum. We start an antibiotic from day one, either because of our practice or because of patient's demand. But that is not a good practice. Most of the upper respiratory tract infections obviously will like have similar symptomatology, are like viral, and which will not get better with antibiotics. We just assume that the antibiotic will provide a secondary infection cover, but that is assumption. It is not proved to be helpful or effective. So wherever possible, avoid antibiotics to save them for the time when the patients actually need them. But obviously, if you have diagnosed pneumonia, the treatment duration depends on severity of the patient's disease. You can do microscopy to diagnose the organism, culture of the common pathogens, but these need to be done before you initiate antibiotics in these patients. Then chest X-ray and sputum examination, routine microscopy can be done. WBC can give you an indication of septicemias. Then obviously we will rule out TB in all these patients. So this is just to show differentiating features of PCP and pneumonia. So like I mentioned, few of these things. Yeah, CD4 is another thing which we need to look at if CD4 is less than 200 or not. But again, patients with less than 200 CD4 will be at higher risk of pneumonia as well. That is another issue there. So WBC will be quite frequently elevated in patients of pneumonia. Chest X-ray will usually show this lobar or consolidation. Unilateral is usually it is unilateral, but um, in fact, if it is bilateral, it's a signs of severity or seriousness, and you will see homogeneous inhomogeneous opacities with air bronchogram or air space consolidation. Because of air in the bronchus, you will see some black lines on the X-ray in a white patch of pneumonia, which is called as air bronchogram. Sometimes it is associated with parademonic effusions, like I said. Cysts are common in PCP, not that common, but there is a risk of, like I said, pneumothorax. But in pneumonia, cysts are rare, but they can be associated with pleural effusions. So I think this is a good slide to see the differences. Then treatment is usually 5 to 7 days. You again, depending on severity, you can start with the oral antibiotic, and if it is more severe, or if you have reports of culture available, you can modify your treatment after some time and switch to appropriate antibiotics. But if it's a severe pneumonia or lobar pneumonia and patient showing signs of severity, increasing severity, you can give an IV antibiotic. And once the patient is stable, then you can switch to oral antibiotic in those cases. So high dose of amoxicillin clavulanic acid will be used in patients like 625 3 times a day. And you can combine that with macrolides. And alternatives are other beta-lactams of cephalosporin, second or third generation, usually for as an oral medication. And in hospitalized and non-severe patient, you can give third generation cephalosporin like ceftriaxone, or beta-lactam antibiotic injectables can also be given. But in patients with severe pneumonia, you can give beta-lactams injectables along with azithromycin or beta-lactams with fluoroquinolones can be given. And alternate therapy is carbamazepines or meropenem, which can be given to patients who are allergic to penicillin. Again, Pseudomonas aeruginosa, or this is one organism which is commonly acquired in the hospital, or hospital-acquired infection, or hospital um, um, or pneumonia happening after hospitalization. If the patient is hospitalized for other reasons and developed pneumonia, this is suspected after maybe like some weeks of hospitalization. And this is again difficult to treat. It is gram-negative bacilli. So the preferred treatment is with piperacillin, tazobactam, and or cefepime, or imipenem, or meropenem. Then alternative treatment is again anti-pseudomonal beta-lactam with aminoglycoside or azithromycin, or you can also give fluoroquinolone in that cases. So for methicillin-resistant Staph aureus pneumonia or MRSA, vancomycin or linezolid is another option. So as you can see, linezolid is access to linezolid in our country is very easy, or all these antibiotics is very easy for that matter. But the antibiotics should be reserved for specific need in specific situations. That is the key, I guess, because if you start giving linezolid to mild pneumonias or vancomycin, then once you have patient of MRSA, you will start losing them because there is no further treatment available. So please make sure that antibiotics are used properly. So quickly, in last 10 minutes, what we have, we'll go through MAC and a couple of remaining organisms. Mycobacterium avium complex intracellular. We used to see this again, not very commonly, but we used to see these patients in past, less commonly these days. Because as I said, if the treatment is being started with as an irrespective CD4 count, patients are usually being started on ART at higher CD4 counts. And MAC occurs if CD4 falls below 50 cells per cubic meter or below 100 cells per cubic millimeter. Patient presents with fever, night sweat, chills, weight loss, very similar to TB. Wasting abdominal pain. It is very hard to diagnose this based on like clinical presentation. But if you see liver, spleen, or enlargement or lymphadenopathy, please suspect MAC in those patients. Diagnosis confirmation can be done by isolating MAC from the cultures of blood and normally sterile tissue or body fluids. So routine prophylaxis is not recommended, but in India, but if it has to be given, it is azithromycin. Then preferred therapy is clarithromycin or azithromycin, and then alternative is rifabutin or fluoroquinolone. And for discontinuing, patient should complete at least 12 months of treatment, and there should not be any signs and symptoms of MAC in those patients. And the CD4 should be above 100 to make sure that immunity has been restored at least for 6 months. Tularomycosis, some of you may not have heard this. It's a new term for penicilliosis. And this is again specific to Northeast, where there are bamboo rats, and especially in Manipur, where you can see these patients. For other places, if the patient has history of travel from Manipur or Northeast and showing these symptoms and signs, you should suspect a penicilliosis, HIV positive, obviously. This is again stage 4 disease. Penicillium, it is caused by thermally dimorphic fungus, which is Talaromyces marnefi or Penicillium marnefi. Geographically restricted to Southeast Asian countries, including northeastern part of India. I've seen a couple of cases in Manipur. That's why I'm mentioning Manipur more. So subacute illness characterized by fever, weight loss, hepatosplenomegaly, lymphadenopathy, respiratory and GI abnormalities. Skin infection, you will see necrotic papules with umbilication appearing on the face and trunk. 40 to 70% of the patients or the extremities. This is very like HIV positive, traveling from Northeast to your place, or if you're in Northeast, obviously you know more than me. And you might have seen so many cases of this. And obviously, this is stage 4 condition if happens if CD4 falls below 200. And these are typical skin lesions of telomycosis. In addition to skin manifestation, patient can also present with shortness of breath or GI manifestations or CNS manifestations, and maybe like thrombocytopenia, bone marrow infiltrations, or elevation of liver enzymes and things like that. If you have a um, you can make a presumptive diagnosis. If you suspect, then you do microscopic examination of Giemsa or rigor Gomori methamine silver stain of the samples of scrapings. Skin scrapings are done, and histopathological demonstration of organism can also be done. PCR can be helpful to confirm the diagnosis. So treatment is with amphotericin B. In these days, we use liposomal amphotericin B, 3 to 5 milligram per kg per day IV for 2 weeks, and then consolidation therapy with itraconazole 200 milligram for daily, twice a day for 10 weeks, and then maintenance therapy of secondary prophylaxis with itraconazole 200 milligrams daily. Alternatively, because again liposomal amphotericin is good to have, it is really expensive. So you can still use deoxycholate or usual amphotericin B, which is 0.62 or 0.721 milligram per kg per day IV for 2 weeks, followed by itraconazole 200 milligrams for 10 weeks, and then secondary prophylaxis until unless CD4 is above 200, at least for 6 months of duration in response to active ART. And a couple of more organisms like histoplasma is a fungus. So usually, again, it is characterized as stage 4. Patient presents with cough, chest pain, dyspnea. We can have CNS manifestations like fever, headache, or seizures, or neurological involvement, and sometimes GI involvement with diarrhea and fever. But this usually presents like a disseminated disease, and that's why it is categorized under stage 4, caused by histoplasma capsulatum usually, and it can be cultured from samples, and detection of histoplasma antigen also can be done in blood and urine, which is very sensitive. So treatment is again with injectable antifungal, which is liposomal amphotericin B, and if you do not have that, use deoxycholate amphotericin, that is usual amphotericin B. Then maintenance with itraconazole, 200 milligram for 3 times a day for 3 days, and then 200 milligrams orally twice a day. So less severe disease, and in maintenance case, if the disease is severe, then or in less severe disease, you can just use the oral itraconazole 200 milligram three times a day, and then for 12 weeks, 12 months, sorry. Then nocardia is again, so this was actually my patient in COE, Tambram, Chennai. So it's again, presentation is very similar to TB. This is a kind of like a consolidation or pneumonia presentation, but the difference is if you do the sputum examination and do smear of the sputum with quinone acid fast stain, it reveals acid fast branching filaments, which is called as nocardia. Again, we need to keep that index of suspicion, because mostly when we start with TB, we actually don't look back. But if patient is not responding, you should need to revive the diagnosis. This is actually a cold staining, and treatment is not with cotrimoxazole, amikacin, or imipenem can be given in these patients. Aspergillus is another fungus, especially in patients who have asthma. In those patients, you will see colonies of Aspergillus. So fungal ball is seen on the CT scan, and sometimes you might see consolidation, and secondary infection also can be seen. So chest radiographic examination need to be done, and treatment is again with liposomal amphotericin B or combination of capsofungin or voriconazole can be considered. Lastly, COVID. I guess everyone has learned COVID extensively in recent years. And we know that it can affect not only lungs and respiratory system, but can also affect the other organs of body. There can be neurological presentation, ocular, dermatologic, cardiovascular, gastrointestinal. So there can be multiple signs and symptoms of COVID. It can be mild disease, moderate disease, or severe disease. I think everyone has done a PhD in COVID, so there is no need to go in any details of COVID. But obviously, if the patients are having higher risk factors, then we need to be very careful and manage the patient according to their signs and symptoms. Yeah, so I think that's the last slide. I don't know if there are any questions. I didn't monitor the
So
chat.
there are no questions in the chat box.
Okay.
Any questions from the participants? Please feel free to unmute your mic. You can also post your questions in the chat box. Any questions regarding respiratory systems? So I don't think there are any questions.
Okay. If no questions, thank you very much, and
Thank you, sir.
have a very good rest of the day, all of you. And thank you, Shweta and Kiran. Thank you.
Thank you, sir. The next session will be held on 6th of April from 2 p.m. to 3 p.m. and the topic is gastrointestinal systems. The feedback poll is now visible on your screen. Please scroll through all the 4 questions and attempt them. Requesting all the participants to please attempt the feedback poll. Kiran sir, we can end the feedback poll now. Thank you so much, sir, for facilitating this session. Thank you to all the participants for patient listening. So can we conclude the session now?
Yeah, Shweta, please. Thank you, everyone.
Thank you, sir.
Bye.